to give you just one or two examples, if you were to have a CHA2DS score of 3, you would have about 3% stroke risk per year. If you would have a CHA2DS score of 7, you would be up to 11%. And the idea to give anticoagulation in these patients who do have such a stroke risk goes back to trials that have been conducted in the 80s of the last century. And I would like to give you two examples of quite a number of these trials. The first one has been published in 1992 in the New England Journal, where Dr. Anticoagulation and colleagues randomized 500 people with atrial fibrillation who did not have a prior stroke. And these were randomized either to placebo or to warfarin with a rather, from today's point of view, rather low INE target that just looked for the primary endpoint of strokes. Now, what they found first was that the bleeding risk was acceptable in the majority of these people, but that giving vitamin K antagonist to these people substantially reduced the stroke risk and brought the stroke risk down to about 1/3 of the stroke risk that has been seen in people not receiving anticoagulation. The second one was the SPAF3 trial, 1,000 people with atrial fibrillation that have been randomized in a, from today's point of view, rather, say, atypical way, who either received, again, vitamin K antagonist with a target RNI of between 2 and 3, or who received the combination of aspirin at a quite high dosage of 325 milligrams and low-dose warfarin at a dosage that did not increase the INR. And again, the primary endpoint was stroke, and in this case combined with systemic embolism. So the results were quite similar to the former trial. Again, if you give warfarin in a way that will increase your INR to 2 up to 3, you will have a tremendous decrease in the stroke risk. And again, when it comes to bleeding, there was no real safety signal. So the comparison between the people who received the standard way of warfarin in comparison to those people who received the combination therapy, they even had less bleedings in these ways. So all this gives us the idea that, just go over this, gives us this, the idea that at least once we have a stroke risk that is higher than the bleeding risk, we should go for anticoagulation in the general population again. And as we know that the risk of clinical significant bleeding is somewhere between 2 and 4%, we say that we should go for anticoagulation if your stroke risk is above 3 or 4%, which then ends up at a CHA2DS score of 3 or 4. And our colleagues then summarize this idea by stating that, again, if you do not have a mechanical valve or severe stenosis, then you should not go for anticoagulation if you have a CHA2DS score of 0 or 1 point, because in these cases, the risk of bleeding would be higher than the stroke risk. There's a maybe for male patients with 1 point and female patients with 2 points. And for all other patients, who again are the vast majority of all our patients with AFib, we should go for anticoagulation if we do not have strict contraindications, because in this case, again, the bleeding risk under therapy is much lower than the stroke risk if we do not give any treatment. And then these guidelines end up by stating that for all these patients, if we go for anticoagulation, then we should go for NOACs, because the risk of intracerebral bleeding is much lower in the general population, again, compared to vitamin K antagonists. So that's the general population. Now, when we come to patients with impaired kidney function, again, I would like to start with CKD stage 3, because this is actually the only CKD stage where we do have some solid data on the question whether or not to give anticoagulation. And this comes from a subgroup analysis of the SPAF trial that I showed you just some minutes ago. Again, this, from today's point of view, rather a typical combination of aspirin plus warfarin combined to warfarin with target ranges. This has been the results I showed you earlier. And here the authors did a subgroup analysis because they had quite a lot of people who had a GFR somewhere between 30 and 60 corresponding to CKD stage 3. And what they found was when they compared the benefit of vitamin K antagonists between people with impaired kidney functions, again GFR between 30 and 60, to those with normal kidney function, GFR above 30, then they found that the benefit was at least as large in people with CKD as in people who did not have impaired kidney function. And when it comes to risk of bleeding, again, there was no real difference in the risk of bleeding when comparing people with impaired kidney function to people with normal kidney function. Surely the total amount of bleeding is higher in people with CKD, but this does not depend upon whether or not you give vitamin K antagonists, and therefore for these people with CKD stage 3, there's quite good evidence that giving these people vitamin K antagonists with a target INR between 2 and 3 is beneficial. I just want to show you again the stroke risk across the CHET score. So this has been done many years ago. There was no CHET-VAS score, there was just one CHET score, but you see the higher the CHET count, the higher the risk of stroke, and this holds true both for people with normal kidney function, the black bars, and for people with impaired kidney function, the red bars. So we can apparently also use the CHET score, or from a today point of view, CHET-VAS score, to estimate the stroke risk in our patients. And then the idea came up whether it might be useful to integrate CKD or CKD stages into this CHET-VAS score. There's a couple of papers in this field, and one of the best ones, I think, has been published in CJASN 6 years ago. This is a large cohort study from France. What they found that you would not have any predictive benefit if you would go for a modified or adjusted CHET-VAS score for people with CKD. So we should just use the very same CHET-VAS score that we use in the general population. Now, if we go for anticoagulation, then again the question, should we use vitamin K antagonists or should we use NOACs? And we do have very good data actually from all 4 NOACs that are available, that for people with CKD stage 3, NOACs are at least as safe and at least as efficient as are vitamin K antagonists. I show you just one example from the Aristotle trial with apixaban. Here, Dr. Hohenloser and colleagues stratified patients who have been randomized either to warfarin or to apixaban according to their kidney function at study initiation, GFR above 60, between 50 and 60, and below 50. Some people may note that this is a slight contradiction because they state Cock-of-Gold GFR, which should be Cock-of-Gold creatinine clearance. I'll come back to that later. So if the bar goes to the left-hand side, people would have a benefit if they take apixaban. If it goes to the right-hand side, people would have a benefit if they use warfarin. And they see that across the stages of kidney function, whether you have fully normal kidney function, the green box, or you have substantially reduced kidney function, the yellow box, then you would have the same benefit of apixaban. The confidence interval crosses the 1 line because these are just subgroups, but you have no term of interaction that is significant. When it comes to safety, so to bleeding, then you see that there's a trend at least for higher safety in people who have impaired kidney function. So apparently, at least again for people with CKD stage 3, we have quite good data that DOACs are at least as, again, safe and efficient as are vitamin K antagonists, and this holds true for the other 3 NOACs as well. So summarize here, in CKD stage 3, we should go for anticoagulation if we do have a CHET-VAS score above 2 or 3, and if we do not have a contraindication, then we should go for NOACs. Then it gets somewhat more difficult if it comes to CKD stage 4, because here we actually have nearly no data from randomized trials. And we have some recommendations which are partly contradictory. So these are the recommendations given by the ESC that state that anticoagulation can be safely used in AFib patients with moderate or moderate to severe CKD down to a GFR above 15. And they give as an explanation, this is because warfarin has been shown to have beneficial effects among AFib patients with CKD stage 3 in SPEF that I showed you earlier. Now this is again somewhat a contradiction, because CKD stage 3 surely goes not down to GFR of 15. So apparently the cardiologists kind of mixed up here a little bit the CKD stages. We only have, for this group of patients, cohort data. And again, in my personal view, best cohort data come from Canada, from Dr. Hun, who looked again across stages of kidney function and who compared the risk of stroke in patients who received, when they have AFib, who received anticoagulation, the blue line, or who do not receive anticoagulation. And on the left-hand side, you see people with fully normal kidney function, GFR above 90, and on the right-hand side, it goes down to CKD stage 3. And across the stages, you see there's always a benefit for people if they do receive anticoagulation. Now, when we go to stage 4, so between 15 and 30, then you see that the benefit is still maintained. Again, you see that the total number of strokes goes up, but the benefit, if you give anticoagulation, remains the same. And the same actually holds true when it comes to bleeding. You see an increase in bleeding risk if you have more advanced kidney function, but you do not really see a safety concern in that you would say that there's an unacceptable high rate of bleeding in these people. Again, cohort data, no randomized controlled trials, but these data, in my personal view, clearly state that at least for people with eGFR between 15 and 30, we should go for anticoagulation. Now it becomes a little bit more difficult when it comes to the question, should we go for vitamin K antagonists or should we go for DOACs? And most of you, again, are aware that all major trials that tested the 4 DOACs which we have currently on the market had exclusion criteria for people who had a creatinine clearance of 30 or 25 for Aristotle. So no patients were actually included with creatinine clearance below 25. But again, we have one study which went down to 25, and because this study was so large, the Aristotle study, in this study we still have about 200 people from a nephrologist's point of view, quite large study, and at least in this 200 people who had a GFR between 25 and 30, when it comes to study inclusion, then we again see no safety signals. Quite to the contrary, we see that these 200 patients did have a substantial benefit if they received apixaban rather than warfarin. But even more important, and that's something we always forgot in clinical practice, is that these studies actually did not look at GFR. Actually, they looked at creatinine clearance. And this makes a tremendous difference. So back to our patient. I told you before she had a creatinine of 1.7, which would give an estimated filtration rate of 27, according to CKD-EP. But unfortunately, all the NOAC studies have been done with creatinine clearance according to Cockcroft-Gault. And when you re-estimate creatinine clearance rather than GFR, you see that for most people, actually the creatinine clearance according to Cockcroft-Gault is much higher than the GFR. And for this woman who would fall below 30 when it comes to GFR, she would be above 30 when it comes to creatinine clearance. And this is, again, the way the study has been done. And this is not one simple example, but this is actually true for a vast majority of people who are with a GFR somewhere between 20 and 30. These are data from our Care for Home study. And I just show you the correlation between creatinine clearance, cock of gold, and GFR, CKD-EPI. And you see, if you, again, focus upon this 30, then you see that many people, this yellow field, who do have a GFR estimated below 30 would have a creatinine clearance above 30. And therefore, they should have, they would have been integrated into the large studies because, again, they just excluded patients with a creatinine clearance, not GFR below 30. And this is also important not just for deciding whether or not these patients could have been included into the study. This is also important for the question whether or not dosages of NOACs should be reduced. Because again, here, the dose reduction always focused upon creatinine clearance, not on GFR. And if we forget about the difference between the two, we will underdose the NOACs in quite a large number of patients. And this underdosing is something risky for our patients. This again has been addressed in a cohort study from the States. They looked at people who had AFib, who received a DOAC, then they checked which patients received the correct dosages, this yellow part of the pie, which patients received a too high dosage, the red part, and which patients received a too low dosage, the blue part. And these 10% or 9% were in most cases patients in whom the renal function has been wrongly estimated by GFR rather than by creatinine clearance. And this is of prognostic implication because people who get a dosage that is either too high or too low have a higher risk, both for stroke and, in case it comes to overdosage, clearly also for bleeding. So again, we cannot rely upon the estimated GFR. Unfortunately, we have to go back to the cock of gold when it comes to dosing NOACs in these patients. So to summarize, in CKD stage 4, my personal opinion is that we should go for anticoagulation if CHA2DS2-VASc score is above 2 or 3. And I think we have quite good data that the majority of these patients should receive NOACs rather than warfarin or Marcumar in Germany. Then finally, the most difficult issue is how to treat patients on dialysis. And here again, we have very contradictory recommendations. The ESC recommended that actually we do not have very good evidence, so what to do when people come to dialysis, we just don't know. The American cardiologists state that patients with AFib, CHA2DS2-VASc score 2 or higher on dialysis, it's reasonable to prescribe warfarin. And on the opposite, KDIGO states that we should not go for anticoagulation in these patients. So completely opposing statements in an area where we do not have any data from randomized clinical trials. And this skepticism when it comes to nephrological colleagues and when it comes to the recommendation from KDIGO goes back to cohort data again that have been published a decade ago. The first one has been published by Dr. Weissman from the DOPS study, where the authors analyzed the annual stroke risk in patients on dialysis with atrial fibrillation who did receive or who did not receive anticoagulation. And because it goes back 10 years, anticoagulation always meant warfarin in these patients. So if there would be a benefit for anticoagulation, which would be somewhat what we would expect, the estimator should go below the line, and if there would, for what reasons ever, risk, then the estimator would go up. And what we would estimate from the general population, going back to the trials that I showed you in the beginning, would be that we would see a reduction in stroke risk of about 70 or 65%, so a hazard ratio going down to 0.35 or something. What they actually found in this cohort study is that if you have dialysis patients who are younger than 65 years, this benefit is lost. And if it comes to older ages, 66 to 75 or even above 75 years, then there's a paradoxical increase in the stroke risk, even though, or maybe because, these people received anticoagulation. So apparently at least a safety signal for dialysis patients that there's not this clear benefit. And the problem with this cohort study and some other cohort studies have been that it was not always evident whether there may be some confounding between ischemic strokes and hemorrhagic strokes, so that maybe you would have some reduction in ischemic stroke, but a tremendous increase in hemorrhagic stroke, which might explain this finding. But we also have some cohort data, again, that tried to distinguish these two stroke categories, such as those presented by Dr. Shan, again from the States, from FMC. And he only focused upon ischemic stroke, and nevertheless also found that AFib patients on dialysis who received no vitamin K antagonist do have a better outcome when it comes to ischemic strokes than patients on warfarin. And there's a lot of other studies that have been published in the last years, and I just give you the latest, one of the latest review articles that has been published. So again, if we would expect that dialysis patients behave as does the general population, then we would have a reduction in stroke risk to a hazard ratio of 0.3. So this gray line, what we actually found is that in the vast majority of these studies, there's no such stroke reduction. So these first studies have been confirmed time and again. And surely most studies report an increase in bleeding, which is obvious because you give anticoagulation. Now, there are two possible explanations why this may happen. One explanation would be that vitamin K antagonists do not only interfere with activation of coagulant factors, and that's actually why we use them, because we would expect them to interrupt this vitamin K cycle, and therefore we would have no activation of factor 9, 10, 2, and 7. But unfortunately, there are some other factors which also need activation by vitamin K. And these other factors comprise osteocalcin and matrix Glar protein, MCG, which are actually very strong anti-calcification factors. So if we give vitamin K antagonists to these people, we stop the activation of these anti-calcification factors. And this is clinically relevant because we do have proof from two sites, actually, from our pediatric colleagues who do a disease, the Coital syndrome, in which this matrix Glar peptide is not active, and these people who do have these mutations have very early calcification in, say, 5 or 10 years of age. So apparently there's a clinical reasoning behind it. And then also when it comes to calciphylaxis, as a very severe calcification of small vessels, then there's a couple of observations that this actually occurs much more frequently in people who are on vitamin K antagonists. And Vincent Brandenburg, who collects this data for Germany, reported that actually we have about 10% of all people on dialysis in Germany who do receive vitamin K antagonists, but when it comes to people with calciphylaxis, 50% of all people have received vitamin K antagonists. So there's a strong association, at least, between use of vitamin K antagonist and calcification. And this issue is just tested in the VITA-VASC trial by Professor Flöge, who will go the opposite way and test in how far application of vitamin K may inhibit calcification. Now, there's a second idea, and I do not go into detail here, that vitamin K antagonists may interfere with transcription factors that again are involved in calcification, and if you would give vitamin K antagonists, you would affect the transcription of these factors, and this again will end up by inducing calcification. Now, this gives us the idea that maybe all these cohort studies that suggest that there's no benefit in anticoagulation for our patients are partly explained by the fact that actually vitamin K antagonists are not beneficial. And therefore that maybe it would be a good idea to go for direct anticoagulants, for DOACs, again also on these people. Unfortunately, there are very, very, very few data for this. And the FDA has allowed apixaban and recently rivaroxaban to enter the market upon data, pharmacodynamical data from very few people, actually just 12 people, in which they found that if you give apixaban in a dose-reduced way to these people, then you do have plasma levels which are quite close to people without impaired kidney function. And this has been enough for the FDA to approve these drugs in dialysis patients. Now, this is not approved in Europe, for the time being, but hopefully we will get some better data, because Professor Wanner and Dr. Reinecke are presently conducting the Axadia trial, in which patients on dialysis who do have AFib will be randomized to apixaban in, again, reduced dosage, or to vitamin K antagonist, because it's German, it's not warfarin, but fenprocommon. And these patients will be followed for 2 years, and we will hopefully have some better data on safety and on efficacy in 1 or 2 years. So to summarize the part for dialysis patients, if we do have a mechanical valve, or if we do have severe stenosis of the mitral valve, we, in my personal view, still have to use vitamin K antagonists. For all other patients, we do not have really good data, and we, for the time being, can choose between either NOACs or low molecular weight heparin on non-dialysis days, or just not to do anything at all. And I would like to sum up by some recommendations which we just published some days ago in German medical journal, where we kind of tried to expand the recommendation from our cardiologist colleagues. This is what I showed you earlier, and we added upon this that if we go for anticoagulation in patients who are not on dialysis but who do have impaired kidney function, then we should give direct oral anticoagulants as long as creatinine clearance, not GFR creatinine clearance, is higher than 25. In case it's lower than 25, but people are not yet on dialysis, we can choose between NOACs and vitamin K antagonists. And for dialysis patients who actually do not know anything at all, we can choose again between NOACs, vitamin K antagonists, heparin, doing nothing at all, or maybe asking our cardiologist colleagues to do left atrial appendage occlusion. And the very last slide, this is what has been recommended just some weeks ago again by the subcommittee of the ESC, who for the first time give a very clear recommendation actually when it comes to the 4 different NOACs that are available, and that give us some more safety, at least when it comes to creatinine clearance down to 15. So that's it. Thanks a lot for your attention.
Thank you very much, Gunnar. We have time for 1 or 2 short question and short answer, please. Yes? Microphone number 4.
Thanks for your nice presentation. Regarding the dialysis patients, I do have used when the low molecular weight heparin on non-dialysis days, which you recommended, but we do factor 10A level on these people. Is that routinely recommended, or?
My major objection to this approach would be that these levels actually give you some discomfort, because you get these levels, then some doctor will see them, will get some kind of anxious and will say, well, they are so high, we just stop that. So in my personal opinion, we used apixaban actually in these patients for some time, and then we got the result from the lab, and some people saw the labs and said, well, we should stop with it. So therefore, I mean, in the large trials, there have been no dosages done by lab values, and therefore, in my opinion, if we go for apixaban, we should rely on the reduction recommended from this data. But that's just my personal...
Sorry, if you use Clexane, low molecular weight heparin.
When we just had last week, again, single patient, but a patient who exactly had this regimen and who has been controlled by anti-10A and who has suffered a stroke. This is just one example, but I'm not really sure whether this is actually beyond any evidence again. We do that from time to time, but I'm not really feel comfort with that.
Sorry, one
No,
last question.
sorry,
about-
interrupt. Short question, short answer. Sorry to interrupt you, I have the last question.
Bengt Falson, thank you very much, Dr. Heine, for a very informative overview. Would it be fair to say that we should follow the same directives when it comes to patients that are, when it comes to renal transplant patients, or are there any special precautions to think of in that respect? I'm particularly thinking of drug-drug interactions with immunosuppressants like calcineurin inhibitors.
In this recent ECG statement, there's a very large table with all kinds of interactions, and they also give some ideas for immunosuppressive medication. There are very few data. My personal opinion is we should go for drugs in these patients. We should measure surely draft levels of the immunosuppressive medications, but we do not have very strong data for that.
Okay.
If I may add just one more thing, it's considering the bigatron, it's, the interaction is a contraindication to use the bigatron in kidney transplant recipients. It's the only valid interaction for this particular population.
Thank you, Guna. Thank you very much for this very nice presentation. I thank you to all of you for your presence. It's time to close this CME session. So once again, thank you for speakers, and especially also for you as an audience to be so patient and to be present till the last minute. Thank you very much.